Okay, great. So what I first want to talk around is the informed consent process, and that is sort of the key central aspect of where we are at in terms of gender affirming care. And when we look at when you talk about care for transgender and gender affirming people in general, we're obviously talking about their general health care, so looking after their HIV and their diabetes and all the other things that needs to be looked after. And as we've spoken in the last training, we therefore want to create safe spaces where people will come to. And one of the challenges we've had is that a lot of transgender people are not feeling safe when they come to facilities because they don't know who are affirming practitioners and who are not. When we're talking about gender affirming healthcare, very important that not all transgender people have the same needs, and it's a process that takes time. So there are different sort of ways in which people might want to be affirmed. A lot of people, it's about social affirmation. So working with non-medical ways of presenting, the way they dress, the way they speak. And when we talk in medicine, we talk about giving them mental health support in terms of affirming their autonomy and their self-determination. Speech therapists helping for things like voice and gender expression. And of course, we spoke last time about the various non-medical gender affirming practices that transgender people use, like tucking and padding, to feel more comfortable in their bodies and in society. Medical gender information that we're going to focus on tonight is offering masculinizing or feminizing hormone treatment, depending on what your patient is requesting. And then I'm not going to spend much time on surgical gender affirmation. That's a very specialized field, and it's looked after by specialists and those teams. So why do we talk about informed consent? And it's helpful to understand where we historically were. So in the old days, just like homosexuality was considered a mental disorder, so trans identities was also considered a mental disorder. It's no longer so. It's been taken out of our psychiatry textbooks. And there was sort of a fear base around gender affirming care. And so there was more of what we call a gatekeeping model. And actually, the gatekeeping model put a lot of responsibility on the shoulders of the healthcare worker. So it was considered that hormone therapy was very dangerous, that it was all irreversible, and that we were terribly worried that clients are going to regret their decision, they're going to suffer terrible side effects. And now you as a clinician had to decide, is this patient trans enough? Do they qualify? And you had to sort of take the weight of responsibility on your shoulders. And if you made the wrong decision and if you did the wrong thing, then you would have to carry the responsibility. Now moving away from this, where we understand being transgender is very much part of, actually, let me just put my video off. There we go. Transgender is very much part of human diversity, just like being gay or being your race or all these different parts of us that we are born with. We now understand that actually it's more about respecting the autonomy of human beings. And just like in medicine, with every single intervention that we did, we will always make sure the other person takes the responsibility. Informed consent puts the responsibility firmly onto the patient's onto the patient's responsibility. Sorry, I was just trying to remove this little stripe here, but never mind. Okay. So when we speak about informed consent, we're talking now about empowering the individual. So we talked last time about the ethical guidelines around providing gender affirming care. And very important, our focus is here on the autonomy of the other person. We are respectful of who they are. We are respectful of their integrity. We are respectful of their beliefs and how they view themselves. And therefore, we become collaborative partners. And as a family physician, I'm very passionate about patient-centered care. And so you as a healthcare worker, your only job is to inform. And of course, you need to make sure that you inform the client about everything that they need to do. But the client decides what's going to happen. The client decides what their needs are, and the client therefore takes responsibility. So from our point of view, very important is that consent is always continuous, and just like consent for all things, it needs to be continually reaffirmed to the patient understand what is happening and what is expected. And please make sure you document. And this is similar when you're taking consent for any surgical procedure, but also think of termination of pregnancies or vasectomies, any of those procedures. We would always make sure that our consent process has been thoroughly documented. And then you as the healthcare worker are not the one that's taking the responsibility. Your patient is in charge. It's also possible to, or very important when we're having informed consent conversations, to understand this unequal power relationship. And we spoke around this last time of how in our society, people who are cisgendered, white, cis citizens, rich, have a lot of power in terms of what they can do in the society. And you have a lot of power in terms of what happens to transgender people's lives. For our marginalized communities in the world that you live in today, if you've got a darker skin color, if you're poor, if you're trans, if you're queer, and especially if these intersect, you actually have much less power to actually change what happens in the world around you. And you certainly have no power in having any effect on these people in the middle's lives. And yet they have an extraordinary power in terms of what will happen in the transgender person's life. And we have to be respectful of that power relationship and making sure that we actually empower our patients and respect the autonomy for them in terms of their bodies. So communication is very important, and building a relationship of trust with our patients. So we talk about a participatory approach where the transgender, gender diverse person stands in the center of this conversation. And as we've said, the Department of Health has now identified all of these centers of excellence. Within the center of excellence, we would have a prescriber, be a family physician, general practitioner, or a primary care doctor. We'll have nurses who can help monitor. We'll have pharmacists that will be providing the medicines, but the transgender person is actually the person who's directing this pathway, and we are simply supporting their journey. There's also various people in the team that we can use depending on the needs of our person in front of us. So we have our non-medical gender affirmations. Some patients might not need hormones, or in addition to hormones, they want to get some help in terms of how to dress, how to put on makeup, how to work with language and speech, how to work with sexual function, and we can refer to our MDT colleagues for that. Also very important is psychosocial support. So being transgender does not mean that you're mentally ill, but being transgender in the world of today is awfully hard. So it's very difficult to be in a scenario where you are constantly being invalidated, or your very existence being debated by people much more powerful than you. And so it's very important that they have that psychosocial support, not only for themselves, but also for the families around them, to be able to manage these journeys within the society. So I always give the example, if you're gay, for example, you can decide to some extent how much you reveal of your private life at work or at school. But if you're transgender and you want to live as per your identity, then you're going to have a battle. You're basically coming out every single time you walk into a shopping center, or if you're at school, at work, you constantly have to navigate these social spaces. And for that, they do need a lot of support. And then for some patients, especially when we talk of children, people under 18, people who have mental health problems, so for example, bipolar, schizophrenia, etc., or people who require surgery, then obviously we're going to be involving our specialists. So to be able to ensure informed consent, you need two basic parts, and that's what informed consent means. And this is just the good old stuff that HPCSA tells us. You first have to make sure your patient has capacity to consent. And in South Africa, all patients over 18 has autonomy and a right to self-determination. So you can't decide which human beings are more allowed to have that autonomy. If you're over 18, especially in South Africa, you have the right to decide about your own life. I'm not going to talk much about children, although children over 12 is already able to consent for medical procedures where benefit outweighs the risks. And obviously one needs to decide whether they have capacity to consent. And so that involves a multidisciplinary team. And again, it's not going to be within our discussion here. So obviously people who are psychotic or under the influence of substances would not be considered capable to consent. And very important, this does mean that you have to be psychotic, you know, the kind of person where you end up considering the Mental Health Act, simply having depression or simply being anxious or being, I hear the word vulnerable used, does not mean that you do not have the right to autonomy. An important part of that capacity to consent means that they have to be able to understand the risks and benefits. And I think this is where we have to be responsible with consent to make sure that our patients are not making decisions when they're in an emotional state. We need to be able to get to a point where they've been able to calmly and cognitively consider all of the information before they make a decision. And that's part of capacity for any decision we ask patients to make. And then very important part of that, because we call it informed consent, the informed bit is about being able to manage and provide information. And we're going to do that now, but you have to be able to manage patients' expectations, and you have to be able to cover the risks, the side effects, and the possible complications. So our informed consent process, and just a couple of slides, because that's sort of fairly straightforward for the majority of people that you see. But it gets more complicated if you might be dealing with a person who has intellectual or developmental disabilities across the lifespan. And the HPCSA writes quite a little bit about that. And of course, this kind of group is not an homogeneous group, and it needs a very individualized, person-centered approach. If you are in a scenario with somebody where you're not sure if they really are intellectually able to understand the decisions that they are trying to make. So not all people, but some people with autism or ADHD might fall within this category. And the reason why is that there's quite a high overlap between neurodivergent. So about 30% of people who are neurodivergent are often also gender diverse. And within that, it's very important to understand that capacity is what you are judging, not the fact that they are simply having autism or ADHD. You are looking at their ability to make a decision. So the thing with capacity is it's never like, oh, you're able and you're not. It's very much about varying degrees, and you need to be able to identify what does this patient understand or not. The only thing I really want to emphasize here is if you are dealing with scenarios like that where you're not sure about their ability to make consent, is to involve, again, your specialists and your multidisciplinary team with people who are familiar with, for example, that particular type of intellectual or developmental disability, and they will very much look at how they respect the wishes of the person and still being able to make sure that the person is making decisions within a capable way. So these are some of the communication tips around people with intellectual disability, but I think this is actually fairly sensible for any consent process, is obviously consider at what communication level the patient is at. So make sure you are explaining things not for your own sake that I've ticked the boxes, but that they actually understand what you're saying. Make sure you use clear and straightforward language. Use concrete examples, practical demonstrations, really interpret for them what is going to happen, and regularly get them to actually explain back to you what they've understood. And I think that's generally actually just good sense when you're doing informed consent. So when we look at the actual informed consent process, I'm actually going to be using the leaflets that comes out of the South African HIV Clinician Society Gender Affirming Guideline. And important to realize that gender affirming hormone therapy is not about validating trans experience. You don't become a trans person because you're on hormones. Hormone therapy is something that assists and supports the transgender person's transition. There's no strict roadmap. It's very individual, and it's very much up to the patient on how quickly one goes. They do not have to have a diagnosis, for example, of gender dysphoria. There's no, again, gatekeeping or tick boxes that you have to tick. In the guidelines, you do not have to have psychotherapy because it's not an illness. So a lot of our transgender patients are mentally very well people. And real life experience, so they don't need to have gone through like a social transition. Sometimes for them, the hormones with the social transition is easier in terms of their particular life situation to be able to go on gender. So there's no lists of criteria you as a doctor need to tick to put somebody on hormone therapy. Also very important is that when people talk about transition, you need to understand what they mean, because we all think about gender very differently. So even what do we mean by gender when we talk about masculine and feminine? And so part of it is being able to understand what the patient thinks they want to see happening when they're talking about going onto gender treatment. So what is the indications for gender-affirming hormone therapy? And simply, it's a desire. So the patient comes to you and says, I have a persistent incongruence between my assigned birth. So what the midwife said when I was born, it's a boy or it's a girl, or increasingly people who might be intersex, and their own inner experience of that gender. And I do find at this stage, usually by the time transgender people make it to our clinics, they've usually have had this experience for many, many years and can articulate very clearly this persistent incongruence. And then all is very important. They must be able to make an informed decision, and they must be able to give consent. They must have the capacity to consent to the treatment, as they will be taking responsibility for the treatment. If there are a significant other mental health concern, and here we're particularly thinking about things like depression and anxiety, it's very important that it's not necessary that that must be first sorted out, because quite often, sometimes a lot of the dysphoria is actually feeding into the anxiety. But in those scenarios, if you've got a mental health concern, then you definitely want to involve your mental health team. And then together you're going to look at, okay, we're going to manage the depression, and we can also start the gender affirming therapy at the same time, because quite often that makes a massive difference in patients. For our psychosocial assessment, it needs to be by a qualified health professional. It could be a prescribing clinician. And it doesn't have to be a mental health therapist. So if you're somebody like a family physician, general practitioner, somebody who's experienced in terms of providing care to patients to sort of comprehensive health care, you can actually decide by, for example, doing your PHQ-9 to your GAD-2, does my patient have depression or anxiety or other issues that I do need to refer them for? Or actually, am I happy that mental health wise, they don't need any extra psychosocial support? So just important, they don't have to have seen a psychiatrist or a psychologist to be able to go onto hormone therapy. So the principles is very much just enforcing what I've said earlier, is this is a partnership model. It's very much collaborative. It's very much continuous, so consent is ongoing. So every single time you touch base with them, you're going to double check if we're still on the same page. It's not like a one-time signature and that's it. And there's particular things that has to be within that informed consent, and we're going to go through these in detail now. So you have to explain the risks, the benefits, the alternatives, and very important, you've got to manage what the expected changes might be. We have to talk about fertility, and we have to talk about that quite a bit. That's probably your most important conversation. There has to be enough opportunity for questions to be able to make sure that they actually understand what has been said. And very much we have this ethical foundation. So we need to respect their autonomy. Beneficence is making sure we do good more than we do harm. So our gender affirming treatment, the benefits of our gender affirming treatment is very well established. We do not want to do harm, so we have to weigh that against the possible risks of giving the treatment and the possible risks, of course, of not providing them with gender affirmation, and then justice. And we covered those quite a bit in the last training. And then very important, make sure you've got informed consent forms that the patient signs, and there's some nice examples in the guideline. So these are the major things that we're going to go through. These are the sort of sections that is in that informed consent forms, and we're going to go through these now one by one. Just a quick thought about your non-binary folk or your gender diverse folk. So sometimes people with non-binary identities who do not feel that they quite fit into either the male or the female binary may also desire hormone therapy. And that's very much then guided by the patient experience. And again, this is not your job to try and figure out why or what. It's simply your job to respect the autonomy of your patient and their own right to self-determination. So the first part of the informed consent process, the first sort of page, I would say, is exactly the same, whether it's feminizing or masculinizing treatment. So I'm going to go through this. So no matter what kind of hormones you're going to be prescribing, there are some basic things that we are going to cover first. And you'll see some of this I've literally copied and pasted